Hello, I'm Matthew Weinstock with Hospitals and Health Networks with continuing coverage of the Health Forum American Hospital Association Rural Healthcare Leadership Conference in Phoenix, Arizona. I'm joined now by Rich Umbdenstock, President and CEO of the AHA. Rich, thanks for being with me.
Thank you, Matthew.
So before we start talking about some of the issues that are top of mind here at Phoenix, I wanted to ask you a little bit about the big news coming out of Washington last week, the bipartisan effort that's come out on the sustainable growth rate, the so-called doc fix. What are your early impressions of what that legislation looks like, what it may mean for hospitals?
Well, it's certainly, I think, a step forward in terms of the policy. We're starting to see some agreement about how to move forward on the SGR and physician payment and the incentives. What's still not there is the payment, and that concerns us greatly. Too many times hospitals have been the pay for patches to the SGR and now other things. And so we're really not at all interested in continuing to be the piggy bank for these kinds of things. The other thing, too, is that at the moment there doesn't seem to be any agreement on whether or not they can go forward with a full fix or whether this is going to be another patch, maybe of a little longer duration, but still a patch. And that's a problem. And they've talked about paying for it again by extending sequestration and cuts to hospitals, and we're not in favor of that.
So really a lot of the unknowns on the funding piece are going to impact how the AHA feels about this going forward.
That's been the case from the beginning. It's been their single biggest problem. They've not tackled the funding issue yet.
Let's talk a little bit about some of the themes that are emerging here at the Rural Healthcare Leadership Conference. One of the undercurrents has been the move to value and where rural hospitals fit into that equation. You know, by some estimates, there are about 17% of rural communities that have an ACO as an example of that. What's your sense of how rurals fit into this environment, and do you worry at all that they might get left behind?
Well, I worry about all our members, for sure, as we make this transition. And I think the broad elements are pretty clear. We do have to be more of an integrated system. We do have to figure out how to live on more fixed payment mechanisms, and we do have to be more accountable for the quality and the safety of the care provided by hospitals. I don't think any of those things are going to change, and those elements form the basis of ACOs. But ACOs are 1 year old. They're still in their formation. I think we're still learning a lot about them. There are questions about whether or not the attributed population is big enough for people to really take that kind of risk. But all of that having been said, rural hospitals are essential to their communities. But like everything in healthcare today, rural hospitals too have to change, have to be part of a more connected system of care of some size or shape depending upon where they stand in their region. They have to be able to reduce costs. We all do. The cost pressure is real and it's not going away. And then, of course, continue to make great strides on the quality and safety side. That too will make them that much more, if they can do the quality and safety side and the cost side, that much more attractive to whatever sort of regional coordinated care system evolves in their area.
But these 25-bed critical access hospitals, obviously, they've got some unique financial and demographic challenges. How hard is it for them to go back into their communities, focus on some of these bigger strategic things at the same time that they've got the economic realities they have to deal with?
Well, critical access hospitals are paid differently for a very special reason, and we have to protect that form of payment. But that doesn't let you off from this drive to value. And so all hospitals across the country are deciding exactly what their configuration of services will be, how they will supplement whatever services they don't provide through relationships with others, and how they'll be part of some sort of population health orientation. And that is the trick for everybody. And we're just going to have to figure that out in every location, including in the rural areas. I don't think rural as a category is going away. Rural America is not going away. But change is obviously on the horizon for everybody.
You moderated a panel at the conference this week on the Hospital Engagement Network, sitting up there with some rural hospitals that were involved in that project to reduce patient harm across the board, a pretty ambitious program by HHS. What are some of the things that stand out to you, particularly about the rurals you worked with?
Well, first of all, the culture is changing. We now know that we can avoid a lot of these events that result in patient harm, and we're showing it. There are hospitals that are going years without particular types of infections or other problems. So the good news is that we know it can be done. So now there's a culture of I want to get it done. I want to do this for my patients. It's no longer a culture of these things happen and it's too bad and sorry it happened to you. They're actually being eliminated, if not reduced to zero. And so the passion around that improvement and the belief that it can and should happen is just terrific.
And are there stories, particular stories that stand out to you?
Well, there are people that talk about putting a face on it. You know, every harm happens to a person. People are starting boardroom meetings with stories about individual patients. They're involving patients in their various committees of the hospital and various councils. Lots of different ways of input. Patients have to be part of that improvement team. And once you believe that, it changes the whole patient-provider relationship for the better. And I think more broadly is going to put even deeper roots for those organizations into their communities. And that's a really important connection in a rural community, because a hospital is so vital to that community, and everybody knows what goes on. Frankly, everybody knows who's in the hospital in a lot of our rural communities, and they want to be part of that success and keep that organization strong. So I think there's a virtuous cycle that goes on because of that close nature of those communities.
The HEN will be continuing through 2014. How do hospital leaders and board members sustain it past that? How do we make sure that this becomes really ingrained in everything that happens in the hospital?
Well, the culture's the issue, and also priority. So it has to be the way we now do business, the way we now operate and function, the way we now care for people, number one. It's got to become a second nature, as we say. It's got to be top priority. It's got to be the lead on everything we do that's in our strategic plan, in our resource allocation, in our orientation of our workforce. Everything has to revolve around this. It's no longer a project. The HEN project has been terrific in providing the support, the collaborative learning opportunities to get this moving at this pace, which is so impressive. But now it's who we are and how we operate, and there's no going back.
Well, great, Rich. I appreciate your time today.
Thank you, Matthew.
And so we'll have continuing coverage of the Health Forum AHA Rural Leadership Conference, both in tomorrow and Thursday's H&HN Daily. I'm Matthew Weinstock. Thanks for tuning in.